Isaiah, thank you, NYCP, for having me here this evening. My name is Joyce McCormack. I am a senior risk management consultant at McCormack Insurance Company. This is a little bit of my bio. I am a nurse by training, ICU in particular. I'm from Queens originally. That's where my accent is from. But I've been up here many years. It just hasn't left me. But I'm really excited to share this presentation with you this afternoon. And my title slide does call addressing the needs of your patient of the LGBTQIA plus population. But just to keep it simple, I will be referring to this population of patients as LGBT or LGBTQ. And it's not that I'm not being inclusive of all, it's just to keep it simple as we go through with the presentation. And we do have a legal disclaimer. I work, McCormack has risk managers of healthcare and legal people. So we always have a legal disclaimer. And this presentation is prepared for informational purposes only. It does not and was never intended to constitute legal advice. And certainly we would want you to consult with your own legal advice if you wanted to see if any of this information could be applied to your own circumstances, and that the statement and views and opinions expressed are solely those of the presenter. And as far as faculty disclosures for myself and our planning committee members, neither myself nor any of our planning committee members have any relevant financial relationships with ineligible companies to disclose. And because this is an education program, we always have educational objectives. And it is our intent that at the end of this presentation, you will be able to identify the inequalities associated with care of the LGBTQ patients, that you can discuss recent legislation affecting LGBTQ healthcare, that you can utilize the strategies for communication and communicating effectively with patients who identify as LGBTQ, and that you can implement measures to mitigate the liability risks associated with treating this patient population. Now, these are the topics that we will go through with this presentation. I promise there are a lot of bullet points, but we will get through all of them. But before I continue, I should point out that this original presentation was developed by my friend and colleague, Mark Andros. He is also a senior risk management consultant with me at McCormack Insurance Company. And this presentation was his capstone project when he received his doctorate in nursing. So he did that 5 years ago. We have been improving it and adding to it as time has gone on. But the original program was Mark's project, and I do want to give him that shout out. So now we'll start with the background and problems. And certainly for LGBTQ patients, when asked, they state that when they do get into the healthcare delivery system or any kind of relationship, that they do find it difficult to reveal their sexual orientation to a clinician. And they feel this way because of a bias, whether it's something that they have felt in the past, that they experienced, or if they perceive a bias when they enter the healthcare delivery system. Clinicians, in turn, have also stated that they do feel uncomfortable asking patients about their sexual orientation for members of the LGBTQ population. And we know that if we do not have good communication with our patients, this can result in substandard of care. So LGBTQ patients may not be completely honest with their healthcare providers. And if they're not completely honest, we can have issues with the type of care that's delivered because it's not going to be appropriate. We know that diagnostic error is a problem in healthcare. And if we don't get all the information that we need to make medical and clinical determinations, if a person doesn't feel comfortable enough sharing with us, we can have issues of diagnoses being missed, incorrect, or not gotten to at all. So for the most part, a lot of members of the LGBTQ community state that they just don't feel welcome within the healthcare setting, and they don't go to get healthcare if they need it. So as healthcare professionals, we know we have a responsibility and a duty to uphold and maintain a standard of care across all cultures and for all people. And it's really important then that we're aware of our own comfort level, our own knowledge base, and our own biases when it comes to the LGBTQ patient population. Historically, we know medical schools and nursing schools have not had a lot of curricula devoted to the care of the LGBTQ population. And even employers over time have done little to incorporate the care of the LGBTQ patient into their staff competencies within their facilities. And even though research indicates that there's a need for this, there is no policy out there. There's no policy addressing how we should develop the standard of care and define the quality of care for the LGBTQ patient. We need to have appropriate insurance coverage for this population so they can receive the health care that they do need. They are vulnerable when it comes to certain activities and certain risk areas, which I'll get to in a few moments. And as healthcare professionals, we do have an ownership to advocate for access for care for all of our patients, but particularly for this vulnerable population. Because as healthcare professionals, we have the knowledge, the skills, and the ability to be their voice where it's needed. Now, in looking at the LGBTQ population, even though this population includes all races and ethnicities or religions or social classes, it's very difficult to determine the total number of LGBTQ patients and people who identify as such. Research will show that it's anywhere between 5 and 10%. This 7.1% came from GLAAD, which is the Gay and Lesbian Alliance Against Defamation, that stated that 7.1% of the population does identify as an LGBTQ member. 20% of millennials state that they identify as LGBTQ, which is higher than the baby boomers, where 7% will identify, and Gen X, where 12% will identify. Now, when we look back, the Institute of Medicine, in as far back as 2011, stated and had a report where they said that there is a need for more evidence-based data for the care of the LGBTQ patient population. And the Joint Commission at that same time in 2011 actually published a field guide where they spoke about the cultural competencies that needed to be included in all facilities for caring for LGBTQ patients. Basically, the underlying message was that LGBTQ patients should feel as welcome in your facility for their care as your heterosexual patients do. And Healthy People, which is a division of the, which is a division of the Office of Disease Prevention and Health Promotion, as early as 2010, noted that the LGBTQ population really should be something that should be studied. And in 2020, they still considered that the health needs of the LGBTQ population does need to be addressed. But when we look back, empirical literature really is scant as to exactly how we should be caring for this population. So the CDC did report that there are numerous adverse impacts from LGBTQ discrimination. First and foremost, it can impact a person's ability to have a job, to have income, and to maintain and have health insurance. It limits their access to high quality health care. And all of this will have a snowballing effect, which contributes to poor mental health, to issues of substance abuse, to engaging in risky sexual behaviors, and in having suicide attempts. And we need to also remember that LGBTQ patients also have their ability to maintain long-term same-sex relationships affected because of how it's viewed by society. And because of this, they engage in more risky behaviors, so they're at a higher risk for getting HIV and other sexually transmitted illnesses. And in general, it's harder to be open about their lifestyle and be their authentic self. And we know that that can cause increased turmoil, increased stress. It limits their ability to get support from their family, from their community, and all of this is going to have a negative impact on their health and their care. Gay, lesbian, bisexual, and other sexual minorities are also more likely to be rejected by family and community. And in fact, researchers have found that those who experience stronger rejection are 8 times more likely to try to commit suicide, 6 times more likely to report very high levels of depression, and 3 times more likely to use illicit drugs or to have risky sexual activity. And studies have also shown that gay, lesbian, bisexual, and transgender individuals are more likely to attempt suicide. And if we're talking about younger patients and younger people, they are twice as likely to attempt suicide than their heterosexual peers of the same age. LGBTQ patients are more likely to use and abuse alcohol and drugs. They will do that at a much younger age. They won't wait for legal age. They will have higher rates of substance abuse, and they will continue these behaviors, and in particular, continue to have heavy drinking into their later years in life. So that's a little bit of the background. Now let's talk about some terms and concepts. So here, first we have sex, and we know that is the biology and anatomy that determines whether someone is male, female, or intersex. Birth sex is that sex that is assigned to a child at birth that's based on physical genitalia. If someone identifies as lesbian or gay, that means they are desirous of an intimate relationship with someone of their same gender. If they are bisexual, they are desirous of an intimate relationship with someone of either gender. And if they are pansexual, that means that they are not limiting their sexual choice based solely on biological sex, gender, or gender identity. Now, intersex is a general term that's used for a variety of situations where someone is born with a reproductive or social anatomy, but it really isn't fitting into what is defined as female or male. And many times being intersex, it may be evident at birth, it may come out later in childhood, or it may never come out. And if someone is asexual, that means that they have a lack of sexual attraction to others, or it is a low or absent interest in or desire for sexual activity. For some, this is considered to be a sexual orientation, but for others, it's considered to have a lack thereof. When we're speaking of transgender people, these are people who identify and express their gender as opposite of their biological birth sex. So people may define themselves as a gender outside their birth sex of that male or female construct altogether, meaning they feel that they have no gender or they have elements of multiple genders. And transgender people choose to represent themselves in the world in a variety of ways. They may change the way they dress, they may change their name, they may change their appearance, or they may medically or surgically alter their body until they are affirming their gender identity as they identify. Gender or gender roles are those traditional behavioral differences between men and women that are defined by culture and society. So it's the way society is going to expect a person to act, dress, speak, and behave, given their gender. Gender nonconforming people are people who express their gender different from what is culturally expected. That does not necessarily mean that they are transgender. So if a boy plays with dolls, if a girl plays with trucks, it's just a preference. It does not necessarily mean that they are transgender. Now, sexual orientation and gender identity are single concepts, and a transgender person can consider themselves to be straight, gay, lesbian, bisexual, or neither. And sexual orientation and gender identity are concepts that can evolve over time. Now, a person who does not identify as either male or female, or may identify as both male or female, is defined as a genderqueer person. And your gender identity and gender expression, gender identity is how do I feel? What is my sense of my gender? And that is, do I feel male or female? Where your gender expression is how do I publicly express and present my gender to others, to the outside. Now, when we look at disparities, there was a poll done in 2017 by the Harvard Chan School, NPR, and the Robert Wood Johnson Foundation on discrimination in America. And this poll found that 18% of surveyed LGBTQ Americans reported that they avoided going to the doctor seeking health care. They had real concerns related to the discrimination that they would face or that they had faced in the past, and they felt that they would be treated poorly because of their sexual identity. And 22% of transgender Americans reported going to see a doctor seeking health care altogether. So LGBTQ people do face discrimination in healthcare settings. And we can all state, and I know we're all guilty, the perception of all of medical providers, at least 99.9% of the time, like Ivory Soap, is that all patients are heterosexual. I know I'm guilty of that as well. But we have to remember and try to reassign and redirect how we are living with this assumption. But because of this, LGBTQ patients are very sensitive and vulnerable to breaches of confidentiality in medical settings. They feel that they are going to be more susceptible to violations of their personhood and of their autonomy because of lifestyle decisions that they have made based on their gender expression, their transition related care, their reproductive decisions, or any other healthcare matter. Lesbian women are less likely to get preventative cancer screenings such as mammography. Studies have shown lesbian bisexual women are also more likely to be overweight or obese. Gay men are at a higher risk of HIV and other sexually transmitted diseases, and LGBTQ individuals do have higher rates of smoking, alcohol use, and drug use. So when you think about these behaviors and their risks, you can also make the direct line to the health risks that are associated to that and why it's so important that we have a welcoming environment for them. When it comes to mental health disorders, lesbian, gay, and bisexual persons are 2.5 times as likely to have one as their heterosexual counterparts. Transgender individuals have a higher lifetime risk for suicide attempts, and LGBTQ adults and their children are more likely to be uninsured and face difficulties gaining access to care. So when you think about things that people do when they're unable to gain access to care and Black market, that's even a higher issue and more of a risk if you've got transgender and LGBTQ patients going to a Black market, say for hormone therapy replacement because they can't get it along conventional means. So now we're going to talk about patient relations, communication, and documentation when our patients are going to come for healthcare. And the first thing we want to do, when the Joint Commission Field Guide that I spoke about at the beginning of this program, is we want to create a welcoming environment. When a patient comes into the environment or the facility, we want them to be able to feel welcomed. We want to have outward signs that are going to say, yes, I will be accepted here. This place will understand and will be able to care for me. So we can do that in a variety of ways. Certainly, we can display materials that reflect LGBTQ lives. You can have same-sex couples. You can have rainbow flags in brochures and literature throughout the office or the facility. With our website, we want to make sure that we're using inclusive language and that we feature LGBTQ-friendly information. When it comes to bathrooms, offer unisex bathrooms. The best thing you can do is if you've got 2 bathrooms, take off the male and female and just label it a bathroom. This way, they don't have to feel stressed that they won't even be able to use the bathroom without it being an issue or being studied. And certainly we want to use gender neutral medical terminology whenever possible. For example, call it a lactation supply as opposed to breastfeeding. We want to make sure that we also have educational brochures that are appropriate and include LGBTQ health topics. We want to post non-discrimination policy that will include that patients will receive care regardless of their sexual orientation or gender identity. And we want to make sure that patients and all patients should understand and have information provided to them for how to file and resolve a complaint if they feel that there was any discrimination while they were at the facility or in the office. And we want to adhere to confidentiality. And we know we have confidentiality when it comes to healthcare, but it really is underlined and in italics when it comes to LGBTQ patients because they are just so vulnerable and they feel that they have to be so guarded when they enter into healthcare. When we're talking about getting information, we want to make sure that whether it's written or electronic, that we're modifying healthcare forms and platforms so that they include a full range of sexual, gender, identity, and expression. We also want to make sure that confidentiality is maintained. And it has been found in studies that when patients are able to do self-reporting for onboarding things and do paperwork without having to have a conversation back and forth, that not only is the information more truthful, but it's more complete because they feel that it's private and it's going to be maintained private because they're handing off, a clipboard or something. So whenever we can do anything where the patient is able to supply the information on their own, that will help with that first basis of building that level of trust. Certainly, we'll talk about staff training in a few slides, but we want to train staff and encourage them to use the patient's preferred name and pronoun. Now, remember with transgender patients, they may choose a different name and sexual identity than what appears on their healthcare information. So if there is a place to include those pieces of information on all intake forms, that's also helpful and very welcoming. And forms should also become more expansive when it comes to single, married, widowed, or divorced. We should have places for domestic partnership because that is also a very big part of the world we live in today. When it comes to communicating with patients, we know it will become easier as anything over time. When we first start, you have a few minutes, it may be awkward, but then we just get past that. And the easiest way to do that is to follow the patient's lead. Ask them, not out of a curiosity, but because we want to make sure that we're not going to be offending them and we want to address them as they want to be addressed. See how they discuss their partners. If we're in doubt, ask the patient, how would you like me to address you? What terms would you like? What pronouns do you like? You're going to be interpreted as being sensitive and caring and not just curiosity because you're asking the questions. And of course, if we slip up, as we slip up with anything, the easiest thing and best thing to do is to apologize and try to do better as we move forward. And of course, we would never want to use any derogatory terminology when we're speaking with these patients, because we know that communication is so important to start that patient-physician relationship, to get that bond, to get that trust. And when we have these open lines of communication, it's going to allow the opportunity for you as a provider to give education to your transgender or LGBTQ patients about what they should be doing for their health. Inquire about safe sex, if they need to have any immunization, to do appropriate screening exams and talk about family planning. And it's also your opportunity to learn what care they may need. Some care may require a referral, but you need to remember, particularly if it's a transgender patient, what types of screenings do they need? Because if we've got a transgender patient, a male to female, they will still need to have a prostate exam. A female to male will still need to have ovarian screenings, pap smears, and mammograms. So we want to figure out in our communication and kind of get a rhythm for how we're going to address these important topics when we have that limited amount of time with the patient in the room. And again, we want to make note of domestic partnerships so that that inclusion is represented in that aspect of care. And when we're looking at transition history, remember that this can change over time. So we want to make sure that we've got it documented, that we're sequential, and we know where our patients are along their journey. It really is going to be uncoupled from any other template. So now when we get to medical management, and that's a little bit of what we covered. You want to recognize that there are shortcomings in knowledge. When we take care of any new patient or when we have any new disease, we always look, we do our research, and then we want to apply and have evidence-based care. Treating LGBTQ patients, we follow that same process. We want to recognize what we don't know, learn what we can, and provide evidence-based practice for them. So we want to get a rhythm to how we're going to do our physical exams. We want to make sure that we address specific healthcare risks with them, as well as discuss any healthcare challenges that they may be experiencing based on our knowledge of the patient, as well as what we know can be risk areas for LGBTQ patients. So we want to have our process for how we're going to collect important and sensitive information about sexual anatomy, development, sexual behaviors of our patients, their history, their orientation, and their sexual identity and their gender identity. We need to make sure with routine care that we are remembering cancer screenings. We need to remember, particularly for transgender patients, that transgender male will require pap smears, transgender females will require prostate exams. So we want to make sure that that is a part of our process each and every time we see these patients. We want to provide prep for HIV because we know that risky sexual behavior and an inability to be able to maintain long-standing relationships does put this patient at a higher risk for HIV. We want to take the opportunity to discuss safe sexual practices and test for STDs. And the mental health piece, particularly suicide screenings, we know we should be doing this for all patients that we see, but for patients in LGBTQ, it's really so important because they are at such a higher risk because of all of the community and elemental things outside of when they're coming for care. We also want to make sure that we've got a complete history. We want to make sure that we have all of the surgical procedures that they have done and know where they are on their journey. And while this is a little bit of a repetitive slide, I will use an example of an OB patient. If an OB patient is seen, transgender people, non-binary individuals, other gender fluid identities, if they do have a uterus, they may elect to have a baby. That does not necessarily make them a high-risk pregnancy. In fact, studies have shown that their pregnancies are no more complicated than a regular heterosexual pregnancy. However, many times they will be referred to a specialist just because they will have the time to be able to work on them and further address and devote time to the emotional and social needs that this patient may require. So we don't want to necessarily transfer patients away, but we do want to make sure that the patient's going to be getting the care at the best place for them, depending on where they are in their journey. And we also want to make sure that we've got community resources that are particular and sensitive to LGBTQ persons and their health needs. So when we're talking about our staff, we need to make sure that education regarding the proper care for LGBTQ patients is performed in new employee orientation, certainly, but it also should be part of annual competencies. And that should also include a review of social media policies and procedures. We want to ensure that staff are comfortable communicating with patients who are LGBTQ and identify as such. And you can do that offering short training and educational sessions. And certainly having that list of resources that are LGBTQ friendly will also help your staff feel more secure that they have something that they'll be able to offer should a need arise. As much as we want to talk about what should be done, we also want to talk about what staff should know they shouldn't be doing and what inappropriate behaviors will not be tolerated and what will happen as a consequence. There should never be laughing, joking, taunting, or mocking. They certainly should understand and know that confidentiality is such an important issue for LGBTQ patients that it's really reinforced and should not be violated. We should educate them that we want them to use when they can, if they know the proper name and proper pronouns for the patient, and that they shouldn't use the improper if you feel that it's not being done just by a slip. We spoke about bathrooms. The easiest thing is just to take the signs off of them, but we want to make sure that they need to understand that if they're not following the appropriate care, that there will be consequences, just as we would for any other patient who is not being treated with sensitivity and properly. There are sensitive areas that shouldn't be discussed unless it's going to directly impact the patient's care. And this is for all members of the healthcare team. Their physical characteristics, their transgender or surgical status. But if these areas do need to be discussed and reviewed, because we want to put the patient at ease and build that trust, take the moment to explain to them why it's relevant, why we are having these questions at this time. And again, remind them, even though they know it's confidential, that they sign a confidentiality form when they come in, that this information is confidential and that you need it because you need to develop the appropriate plan for them. And of course, we need to keep everybody accountable. We should be doing this in all aspects of our care delivery. But if we do have a colleague who does use a wrong name or pronoun, or if they make an insensitive comment, we should politely correct those behaviors. And like any time we want to see behaviors change for the better, we want to have that discussion close to when the infraction happens so that they can understand that that wasn't appropriate and why it wasn't appropriate. Now, when we come to policy and procedures, certainly there should be a non-discrimination policy that is posted that states that we provide care for patients without discrimination, including but not limited to discriminations on the basis of race, ethnicity, age, sex and gender, sexual identity, sexual orientation, socioeconomic status, religion, insurance status, source of payment, country of origin, immigration status, physical ability, and mental ability. And certainly the Bill of Rights should also be modified to include information regarding LGBTQ patients. At the admitting and registration form, as I said before, if we are able to get some information that the patient is able to fill out themselves, either in pen and paper or on an iPad, we will get more complete information if they're able to do that and self-report. But we want to make sure that our gender fields are expansive so that we have more than just male or female. We want to make sure, recording the name, we do have to have the legal name that's attached to the insurance, but if there's a place, if we can put an optional name, a preferred name, and preferred pronouns, that also goes a long way for a welcoming and acceptance feelings on the part of your patient. And the domestic partnership also will underline that. When we're talking about room assignments, and this would be in the, obviously the hospital setting, we don't want to assume that a transgender patient should automatically be in their own room. Now, most hospitals have converted many rooms to private rooms, but not everyone does. But when we're talking about the patient's room, they can be put into a room for the sexual gender that they identify as. If there is an issue with that, then if the issue is with the other roommate, then the roommate can be put into a different room, because a transgender patient or a patient who identifies as a sex different to the one that they were given at birth does not, has the same right to having that, to be in that room as the other patient. Restrooms, again, just make them all unisex, and that takes care of it. And when we have tracking boards, whiteboards are wonderful in the patient's room, but we want to be sensitive to any information that we put on there. Some people are very private about all of their healthcare needs, but particularly if you have a transgender patient, you don't want to put something on the whiteboard that is going to draw attention to that. You want to protect their privacy as much as we can. When it comes to insurance, unfortunately, there are still many insurance companies that do deny coverage for transgender care and population, and for their treatments, particularly with hormone therapy replacement. So when they're not able to get that, it can cause serious harm to them physically, but they also can have increased depression, suicide ideation, and they may look to self-medicate or do self-surgery. We spoke about the Black market before, and really going outside and getting medication on the internet or someplace like that can cause a whole host of other problems that we really hope insurance companies can get a little bit more up to date on that. Remember that many times when there is a gender-specific treatment, insurance companies will require that the individual be identified as male or female. So they may deny coverage if that is not identified. But happily, a number of insurance companies are beginning to understand that they should be providing coverage for transgender patients who have gender dysphoria, who it is medically necessary to have hormone replacement therapy, to have sexual reassignment surgery. Now, when we talk about legislation, We'll go back a few years to 1969, and this was the Stonewall riots. And in the early hours of June 28th, 1969, there was a gay club in Greenwich Village in New York City that was called the Stonewall Inn. And there was a riot that sparked actually 7 days of protesting because the community around the Stonewall Club were incensed at the way that the patrons and the employees were treated by the police when they came to do their raid at the Stonewall Inn. And on the year anniversary of those riots, on June 28th of 1970, thousands and thousands marched in the streets of New York City from the Stonewall Inn to Central Park in commemoration of that event. And for many, this was America's first gay pride parade. They called it the Christopher Street Liberation Day. And in fact, in 2016, President Barack Obama designated the Stonewall Inn, Christopher Park, and the surrounding streets and sidewalks as a national monument. There was also New York State legislation, and in January 2019, then Governor Cuomo signed Senate Bill 1046, which designated that anyone engaging in sexual orientation change efforts in any patient under the age of 18 years of age would be considered professional misconduct. And this would be mental health care professionals. And he also signed Senate Bill 1047 Gender, which basically prohibits discrimination based on gender identity or expression. And it basically would put it under the statutes of hate crimes. In January 2019, he also signed the Assembly Bill A2707, which outlawed the so-called gay and trans panic defenses, which basically states that defendants cannot use a victim's sexual orientation, gender identity, or gender expression as the defense in a criminal case. And then in December 2022, Governor Kathy Hochul signed some legislation to address healthcare disparities in LGBTQ communities. And she signed legislation A9604-8937, which basically authorized runaway and homeless youth under 18 to consent to their own medical, dental, or health and hospital care. And this is because LGBTQ youth are disproportionately represented in runaway and homeless youth populations. So they wanted them to have a way to get access to medical, dental, health, and hospital care. And then legislation A1880/X2534A requires home health aides and nurses aides to receive training in working with patients with diverse sexual orientation and gender identity. As far as legislation goes on the federal side, we know that Title IX is the Education Amendments Act of 1972, which states that no person in the United States shall, on the basis of sex, be excluded from participation in, be denied the benefits of, or be subjected to discrimination under any education program or activity that receives federal financial assistance. And the courts had already ruled that Title IX protects against gender identity discrimination. Then the Supreme Court was looking at Title VII of the Civil Rights Act of 1964, and it began hearing cases in October of 2019 and delivered up their decision in June of 2020, which basically prohibits discrimination, employment discrimination, based on race, ethnicity, age, sex, gender, sexual orientation, socioeconomic status, religion, insurance status, country of origin, immigration status, physical ability, and mental ability. And then we've got HR 5, which is the Equality Act, which is pending legislation at the federal level. And what this is basically looking to protect and extend civil rights protections to the LGBTQ patients, prohibiting discrimination based on sexual orientation and gender. And this would go to employment, to housing, to banking, financial, and other measures. As far as pending legislation, when we look back a few years in 2021, that really was the worst year on record for LGBTQ patients. There was an unprecedented number of states that enacted a record-shattering number of anti-LGBTQ measurements into law. 2022 could have been the most anti-trans legislative year in history. There were roughly 280 proposals in state houses across the country that were aimed at transgender patients alone. In 2023, there were over 500 anti-LGBTQ bills introduced in state legislations across the country. And so far in 2024, more than 275 bills are targeting the LGBTQ rights in state legislatures. As far as professional organizations, the American Medical Association does support a ban on LGBTQ conversion therapy. And in addition to advocating for policy changes on the federal level, the AMA also plans to develop model laws to guide state legislatures. The American Dental Association developed a diversity and inclusion plan that began in 2020 with an end date of 2025 to support progress across the nation to be more inclusive. And the American Nursing Association advocates for the right of all members of the LGBTQ population and supports efforts to defend and protect LGBTQ human and civil rights. So with all of this information, what are the things we can do from a risk management standpoint to protect your patients, to protect your practice, to provide quality care, and to keep patients safe? As I said, the first thing we want to do, normally we always start our tips as things we should do and have a to-do list. But here we actually go the backwards way and say we don't want to do things. And the first thing we don't want to do is make assumptions and presume things. We don't want to presume that all of our patients are heterosexual. We don't want to assume that all of our patients will use traditional labels. We need to be leery that we're not assuming someone's sexual orientation based on their appearance, or that we are doing it based on the appearance or behavior of their partner or someone else with them. We want to make sure that we ask and don't assume that sexual behaviors, that sexual identity has not changed since we last saw the patient. We want to not remember and not assume that transgender patients are gay, bisexual, or lesbian. And we don't want to assume that if someone states that they have a bisexual identity, that that's just a phase and that they'll get through it. We also recommend having an advisory council for LGBTQ issues. Don't wait until the laws are enacted or passed, or worse, for a lawsuit to occur to make the appropriate changes. Do what you can and be proactive. Have an internal assessment done so that you can see from a baseline standpoint, what is the knowledge level of staff? What are the feelings? How are biases? Are there biases? And we can do that in a number of ways: questionnaires, conversations. And then you want to have a policy and organizational initiatives that will address how interactors with LGBT patients, what should they look like? And you want to make sure that staff interactions start from a place of mutual respect, courtesy, and professionalism. If you use your electronic health record, work with your vendor to make sure that all of your fields are as expansive and as inclusive as they can be. If there is an upgrade or something that you can do, so that you can be sensitive and have that information readily available, so that people don't have to go flipping through to know how someone would want to be called, what name they would want to use, or what pronouns they want. You want to make sure that you keep a current list of resources that are LGBTQ friendly and welcoming, and have guidelines for implementing care of LGBTQ patients. You want to use current terminology. You don't want to say something because, again, if we slip up, we can just apologize and try to do better. Want to involve patients in their decision-making. We should do that with all of our patients, but particularly for LGBTQ patients, they will feel that they have a stake in this and that they are part of a real team and that there is a real relationship there. We want to learn and keep abreast of evidence-based practices, and we want to be cognizant of biases. We want to try to recognize whether they are our own, the practice, the facility, the community, and then do what you can to help educate and broaden the horizon. We want to work diligently to remove any unintended bias in our behaviors. And of course, we want to be an advocate for our LGBTQ patients. Now here there are some resources and some references that are included in the slide program. I know that was a lot of information and a lot of slides, but I wanted to make sure we got through. In case there are any questions, I'd be happy to take, and I'm happy to answer, but if I don't, I'm also happy to say I can get back to you. And thank you all for joining us tonight.